Our next session is session 4, and it focuses on healthy diets for health improvement in children. Well, I'd like to say that despite the undisputed importance of nutrition to the health of children, malnutrition, either as obesity or undernutrition, continues to be a critical challenge globally. This is more so in a world that is rapidly changing and facing other challenges to sustainability. Our next speakers, therefore, will address this topic from a point of view of what the burden of malnutrition is and what can be done about it. Our next speaker is Professor Dr. Mohammed Yazid Jalaluddin. He is currently the head of Department of Pediatrics, Faculty of Medicine, University of Malaya. He is the immediate past president of the Asia Pacific Pediatric Endocrine Society and the Malaysian Pediatric Association. He has researched into nutrition, obesity, and type 2 diabetes mellitus in children. His work has appeared in the prestigious New England Journal of Medicine. I dare say that is a global voice in the area of malnutrition. He will be speaking to us today on the topic, the global burden of malnutrition, overview of current status. A warm welcome to Professor Jalaluddin.
Assalamualaikum warahmatullahi ta'ala wabarakatuh, and good day everyone. First, I would like to thank FrieslandCampina for inviting me to speak today in their global conference on the global burden of malnutrition, overview of current status. I am Professor Dr. Mohammed Yazid Jalaluddin from Kuala Lumpur, Malaysia. So today I would like to speak to you on the global perspective, that is on the overview of prevalence of malnutrition among infants and young children. Then we would like to look into the role of nutrition in current situation, especially during this COVID-19. And we would then look into the opportunities for prevention and cure of malnutrition. Before we move on, we probably need to look into the normal growth pattern of a child. In the first 2 years of life, there will be a rapid growth whereby children will grow between 10 to 20 centimeters per year, and the next 2 to 5 years, the height gain is slightly lower, between 7 to 10 centimeters per year, before they grow between 5 to 7 centimeters per year between 5 years old, or about 10 for a girl and to about 12 for a boy. And then they will have this increase in growth spurt during adolescence before everything stopped when the epiphysis fused, usually by the age of 14 in a girl and 16 in a boy. So what drives this growth? The main important things is that we need to look into these 3 different phases: the fetus and infancy phase, childhood phase, as well as adolescence phase. As you can see from here, nutrition play a great role in terms of them achieving their high potential. Apart from that, during fetus and infancy period, IGF-1 play a big role, growth hormone during childhood, and sex steroid during the adolescent period. And here I would like just to show you that the growth during infancy is most strongly influenced by nutrition. Almost about 27% of energy is consumed for growth during the first 4 months of life. Here I would like to just show you the nutrition, which actually the main important critical factor that modulate the levels and effects of hormones as well as the inflammatory cytokines at the growth plate level. When a child had some malnutrition issues, there will be a negative effect on certain endocrine functions, endocrine hormones like the thyroid hormone as well as the IGF-1. Malnutrition also will increase FGF21 that will also lead to poor growth at the growth plate chondrocyte. Malnutrition, on the other hand, also causes increase in the inflammatory cytokines like interleukin-1 beta, interleukin-6 or TNF-alpha, which has a negative impact also on the growth plate chondrocytes. So it seems that nutrition is not just about calorie, but nutrition also affects the hormones as well as inflammatory cytokines. So infants and young children around the globe are not growing well physically and mentally. Globally, 1 in 9 people is hungry or undernourished, and in total, 149 million children under 5 years are stunted. Let us look at what undernutrition is. Undernutrition is an imbalance between nutrient requirement and intake, resulting in cumulative deficit of energy, protein, or micronutrients that may negatively affect the growth, development, and other relevant outcomes. And diagnosis of malnutrition can be looked into many different ways, such as the height, the weight, the mid-upper arm circumference, as well as the growth velocity. Now let us look at some definition that tells us about malnutrition, which are stunting, wasting, and underweight. Stunting is when the height for the age of the child is below -2 standard deviation, while wasting is when the weight of the child is below -2 standard deviation compared to the child's height, and underweight is when the weight of the child is -2 standard deviation compared to the children of the same age. Alright, let us look into a little bit more detail of all these different categories of malnutrition. Stunting. So stunting refers to a child who is too short for his or her age. Children affected by stunting can suffer severe irreversible physical and cognitive damage that accompanies stunted growth, and the devastating consequences of stunting can last a lifetime and even affect the next generation. Wasting, on the other hand, refers to a child who is too thin for his or her height. Wasting is the result of recent rapid weight loss or the failure to gain weight. And a child who is moderately or severely wasted has an increased risk of death, but treatment is possible. What about overweight? Overweight refers to a child who is too heavy for his or her height. And this form of malnutrition results when energy intakes from food and beverages exceed children's energy requirement. Overweight increases the risk of diet-related non-communicable diseases later in life. So some children suffer from more than one form of malnutrition, such as stunting and overweight, or stunting and wasting. However, there are currently no joint global or regional estimates for these combined conditions. And the more recent data that was published by the UNICEF, WHO, and World Bank Group under the title of Levels and Trends in Childhood Malnutrition in March 2021 will be looked into over the next few slides. Okay, before we move on to that, let us understand what is stunting. Height is one of the most sensitive indicators of well-being because it combines the external influences of nutrition, economic wealth, healthcare, social equality, and other important socio-economic factors. And stunting is the impaired growth and development that children experience from poor nutrition, repeated infection, and inadequate psychosocial stimulation. Children are defined as stunted if their height for age is more than 2 standard deviations below the WHO child growth standards median, as I mentioned earlier. So, globally, there are about 21.9% prevalence of children with stunting. And stunting, as you can see from here, affects about 1 in 3 children in South Asia, Eastern and Southern Africa, as well as West and Central Africa. If we look at the Asia and the Pacific region, we can see that quite a number of countries in this region who falls into the WHO category of very high prevalence, which is above 30%. Why is it important to talk about stunted growth? This is important because stunted growth and development does not just involve the child, but it also involves the household as well as the community. And when a child is stunted, the child may fall into the cycle of stunting, a stunted child will lead to the malnourished young girl who will then become a malnourished mother. A malnourished mother would then get pregnant and deliver an underweight baby. And if this continues, this will lead into the cycle of stunting. This cycle of stunting needs to be broken so that this problem of stunting does not lead to the next generation. Why is it important that we look into stunting? Stunting has all these problems in terms of short-term effects and long-term effects. Stunting leads to impaired brain development, lower IQ, and weakened immune system. In the long run, stunting will lead to smaller stature. It can also lead to lost productivity and healthcare costs. And because of the issues of stunting, these people are more likely to become overweight or obese in their later life. And this will lead to greater risk of diabetes and cancer, as well as premature death. So the lifetime cost of stunting is huge. A child who is stunted are 4 times more likely to die compared to those who are not stunted. In terms of IQ, they are 11 points lower IQ compared to those who are not stunted. When it comes to the adults, the income of adults who are stunted is 22% less compared to those who are not. And in terms of economy, stunting contributes to the losses in GDP as high as 60%. So now let us look at underweight. As you can see from here, there is a very important problem of underweight in the countries in the Southern Asia. As you can see from here, in India, underweight the prevalence of underweight is as high as about 40 to 45%. So what about wasting? Globally, the prevalence of wasting is about 7.3%. However, Southern Asia has the highest wasting prevalence at 14.1% compared to any sub-regions in the world. We look at the number of children affected by by wasting. This group of children, more than half of them are living in Southern Asia. And if we look at the children who are affected by severe stunting, you can see from here that out of 13.6 million who have severe wasting, 10.3 million of them resided in Asia. So what about overweight? Globally, the prevalence of overweight is about 5.9%, and a number of countries has higher than that in terms of the prevalence. That will include Egypt as well as in Australia. So if we look at the trends of stunting, wasting, and overweight over the last 20 years, we can see that stunting has reduced over the last 20 years from 33% to about 22%. However, overweight has increased from 5.4% to about 5.7%. Wasting has just been recently looked at and now stands at about 6.7%. So most children with malnutrition are currently living in Africa and Asia. If we look here in 2020, more than half of all children under 5 affected by stunting lived in Asia, and 2 out of 5 live in Africa. If we look at wasting, more than 2/3 of all children under 5 affected by wasting live in Asia, and more than 1/4 live in Africa. And when we look at overweight, almost half of all children under 5 affected by overweight live in Asia, and more than 1/4 live in Africa. So the issues of malnutrition in terms of stunting, underweight, and wasting is not just very prevalent in Asia and Africa, but overweight, or the other end of malnutrition, also are more prevalent in these 2 areas. Yes, we understand about stunting has been declined over time, but if you look at the different income countries here, we noted that stunting has declined by half only in the upper middle income countries. However, overweight is rising steadily, moving further away from the global target. Countries from the low income and lower middle income has not shown much of reduction in terms of stunting issues. When we look at the upper middle income countries, here again it depicts that the upper middle income countries have half the number of children affected by stunting in the last 20 years. There is a reduction of about 49.1% in the upper middle income countries compared to 28.3% in the lower middle income countries. Unfortunately, for the low income countries, there is an increase in the prevalence of stunting, as you can see from the left side. If we look at the overweight, you can see that the overweight prevalence has increased in the upper middle income countries, but has been quite static in those lower middle income countries and the low income countries. So what about the progress towards the 2030 SDG? As you can see from here, for stunting and wasting, about 25 to 28% of the countries are doing very well. However, for overweight, only 17% of the countries involved are going towards the 2030 SDG. More work needs to be done to improve this problem of malnutrition, of stunting, wasting, and overweight for children below 5 years. Now, let us move on to the nutrition part. I would like to just define some of these dietary terms for the benefit of the clinicians. So minimum dietary diversity. The minimum dietary diversity is a proportion of children aged 6 to 23 months who received a minimum of 5 out of 8 food groups during the previous day. What is minimum meal frequency? Minimal meal frequency is a proportion of children aged 6 to 23 months who received solid, semi-solid, or soft food, including milk feeds for non-breastfed children, the minimum number of times or more during the previous day. A minimum acceptable diet is a proportion of children aged 6 to 23 months who receive a minimum acceptable diet, and this indicator is composite of children fed with minimum dietary diversity and a minimum meal frequency. Why is it important? This is important because nutrition is the key factor to avoid the problem of stunting, wasting, and overweight. Dietary diversity really matters because it ensures children receive all the nutrients or non-nutrients they need to grow, stay healthy, and reach full development potential. Dietary diversity also prevents undernutrition, including micronutrient deficiencies such as iron, zinc, and vitamin D. Dietary diversity establishes good eating habits that can persist into later years. How does Malaysia perform against other countries in the region? So as you can see from here, our MDD is about 66.4%, which is slightly lower compared to the countries with lower number or lower prevalence of stunting, such as Thailand and Vietnam. Malaysia, in fact, has a higher MDD compared to the countries with a higher prevalence of stunting among the countries in Southeast Asia, as you can see on the table on the right side. It has also been shown that from the UNICEF Global Database 2020 that less than 1 in 5 children receive a minimum acceptable diet in the low middle income country. Only about 55% achieve the minimum meal frequency. Only 28% achieve minimum diet diversity, and a small number of just 18% achieve the minimum acceptable diet. There's a lot more things that we need to do in the low middle income country to prevent further problems of malnutrition. And this is more important during this period of COVID-19 situation, whereby it is very difficult to even put food on table in certain group of families in this region of low and middle income countries. Let us look at the other part of nutrition, which is the protein intake. It has been shown that human height is correlated with protein intake. Male height in developing countries correlates with protein quantity, whereas male height in developed countries correlates with protein quality. Low protein quality can explain the unexpectedly short height means in the highly developed countries of East Asia and wealthy Asian oil superpowers. And this cartoon here just tells us that globally, majority of children are eating only one type of animal source food or not at all. As you can see in the pink color, it is here to show you that children in South Asia, Eastern and Southern Africa, as well as West and Central Africa, only take about 0 or even just one type of animal source food in their daily intake of protein. And these are the areas with the highest prevalence of stunting, as I showed you earlier. Therefore, it is very important for us to look into protein intake in these children from these regions. So what is protein quality? Protein quality is a measure of the quantity of essential amino acid and the digestibility of protein sources to fulfill the growth and maintenance requirements of the body. Although hundreds of amino acids are found in nature, only 20 amino acids are required to make all the proteins found in the human body, and 9 are essential and must be acquired through external sources of proteins. The efficient utilization of amino acids is dependent on the availability of all essential amino acids. When an essential amino acid, which is the limiting EAA, is not provided in adequate amounts in the diet, utilization of other EAA will be limited to the rate at which the limiting EAA is available, as you can see on the left. So low quality protein causes a barrel with a short stem, and because of that, the child will have less amino acid that is essential for their growth. In fact, if you look on the right, if the child receives high quality protein with a barrel with high stem, the child will be able to receive all 9 essential amino acids, which is optimal for their growth. So infants and children have higher protein and essential amino acid requirement per kilogram of body weight per day when compared with adults. So high quality protein complete with EAA must be provided to help support children's growth and development, as you can see from this cartoon. Low quality protein can lead to suboptimal growth due to limiting essential amino acid. If a protein is inadequate for any essential amino acid, the utilization of other EAA will be limited, thus decreasing growth potential. As you can see from here, if the child has limited utilizable EAA, the child will then have suboptimal growth. And if the child really receives a good amount of EAA, then the child will definitely have an optimal growth. Animal-based protein, such as milk, has higher protein digestibility and quality compared with plant-based protein, as you can see here. Milk protein concentrate and skim milk powder has excellent or high quality protein at 105 and 120 compared to the plant-based protein such as soy and soy protein isolate or pea protein concentrate, as well as wheat. So animal-based proteins are more digestible and therefore higher quality than plant-based proteins. And in a study in Indonesia by Dr. Sharif Damayanti have shown us that growing up milk consumption of 300 ml per day is associated with less stunting. So why are all these important? This is important because brain development of the child depends on the nutrition. Child with stunted brain development has poor brain development. Child with stunted has poor brain development, as you can see on the left. And for those children who are healthy and cared for, their brain development is much better, as you can see on the MRI on the right side. This again showing you how it looks like on the MRI when it comes to normal healthy child brain compared to a stunted child. There are some studies that have shown that catch-up growth among undernourished children is positively associated with cognitive function. Recent studies have shown that children in Ethiopia, India, Peru, and Vietnam at the age of 8 years who recovered from early age stunting perform better in mathematics, reading, and vocabulary comprehension than those who stayed persistently stunted. Another study showed that children aged 11 years who had catch-up growth achieved better academic results than those who were persistently stunted from 4 to 8 years of age. And these results suggest that the potential window of opportunity for rescuing neurocognitive deficits goes beyond the age of 2 years, up until 8 years of age, which is in line with prefrontal cortex development and ongoing synaptogenesis at that age. So it is important for us to help this group of children to achieve their optimal growth in order to achieve a good cognitive function and neurodevelopment. So as we can see from here, brain development in early years, yes, it is very much important in the first few years of life, but we also understand that angular gyrus and Broca area, together with visual cortex and auditory cortex, as well as prefrontal cortex, continue to grow up to the age of about 8 years to about 14 years. Therefore, we need to rescue these children and help them to achieve good growth during this period of time so that this will improve their neurocognitive function. So again, this slide shows us the importance of interventions in improving cognitive outcomes among undernourished children. Micronutrient and macronutrient supplementation can improve linear growth and neurocognition to a lesser extent, as you can see from the one on the left side. For children aged 0 to 60 months, stimulation-based intervention can improve on neurocognitive development. So a combined approach may help in achieving optimal anthropometric and cognitive development. Postnatal supplementation with micronutrients such as vitamin B12 and folic acid and macronutrients such as animal protein such as milk will lead to better linear growth. Foods fortified with calcium, iron, zinc, vitamin B2 and high quality protein will improve cognitive outcomes. And with the presence of stimulation interventions, this will lead to better learning opportunities and improve neurobehavioral and cognitive development. So what about intervention in children who are overweight? A recent study that was published in 2020 has shown that parents' engagement is important in the interventions to prevent or reduce obesity in children from birth to 5 years of age. So a particularly influential time period is the new motherhood, whereby mothers during this time are very receptive to health messages. Studies focusing on infant feeding and weaning practices, as well as anticipatory feeding guidance and responsive feeding, has shown positive effect. Teaching these new mothers to discriminate between hunger and other sources of distress, as well as hunger and satiety cues, play a very important role. The ability to influence obesity risk factors at this early age suggests a need for universal provision of engaging infant nutrition practices, particularly to families living in areas of deprivation. So for families who live in the deprivation, recruitment of deprived families is a big challenge. When barriers to access for parents were not addressed, the dropout rate was high with lots of missing data. So intervention should focus on parents as change agents. There is a need to address accessibility or motivational issues to enable parents to participate. There are studies that shows community approaches is also of importance. Engaging layers of society surrounding children, such as children's services, schools and homes, and thereby support behavioral change is important. Most studies, however, did not have long-term follow-up of the interventions. In this situation, cultural sensitivity is an influencing factor and need to be. The other way of looking at this is through the multi-level studies. It is more likely to be effective because they included different elements of society and surround children such as schools, and those who are highly influential in the early development of children, i.e. the parents and childcare. It is also important for us to look at the effective studies at the preschool level. The preschool children studies is mainly done through the school health professionals, and this effort is important to address child rape, but it is limited by a lack of capacity, lack of clear protocols, challenges of engaging the parents, and insufficient training in childhood obesity and related lifestyle issues. So all in all, it is important for us to make sure that we take care of malnutrition in children below 5 years, be it stunting, wasting, or overweight. So I shared with you some of the factors that lead to this problem, as well as some of the factors that some of the things that we can do to overcome the problem of malnutrition. So in conclusion, understanding the pattern of growth and maintaining or achieving optimal linear growth during early life is important, as it is the link that is directly linked to the cognitive development. Poor nutrition leads to stunting, wasting, and overweight, which may lead to poor cognitive development. Nutrition, especially complementary feeding practices, remain far from optimal, and the nutritional gaps during this crucial period of COVID-19 need to be addressed. Animal protein, in particular milk, is important to support growth, as it contains not only the 9 essential amino acids, but also calcium, and can be further fortified with vitamin D, iron, and zinc. In the case of children with suboptimal growth, such as failure to thrive, stunting, or even overweight, there is still a window of opportunity to catch up with the optimal height potential and academic achievement if stunting is recovered before the age of 8 years. Thank you very much for your attention.
I'd like to thank Professor Jalaluddin for that deeply insightful presentation, and the statistics that we've learned call us to further action as experts in the field of nutrition. Thank you very much. Having looked at the burden of malnutrition globally, it is only reflective on our part to then look at the regional status and successes in combating malnutrition. In my view, a discussion of this nature would be incomplete without examining critically developing nations or regions of the world, as well as the developed countries of the world, so that from these two broad divides, one could see what lessons may be learned from either side and what success stories may be shared. This next part of our conference focuses on the regional status and successes in combating malnutrition, and there is a focus on Europe, Asia, and Africa. There is an emphasis not only on the science and what environmental factors to consider, but there is also an emphasis on policy, which makes this a broadly biopsychosocial approach to this discourse on malnutrition. Our first speaker in this segment is Professor Dr. Ma Guansheng. He is the current chair of the Department of Nutrition and Food Safety, School of Public Health at the Peking University. He was with the World Health Organization Department of Food Safety and Zoonosis between 2009 and 2010, with more than 120 publications in peer-reviewed journals. He is undoubtedly an expert in nutrition and health. He will be speaking to us today on the control and prevention of childhood obesity policy and action in China. A warm welcome to Professor Guansheng.
Ladies and gentlemen, dear colleagues, it's my great pleasure to share with you the policies have been released and action have been taken in fighting with childhood obesity in China. My talk will cover the four following areas. One, the prevalence and trend of childhood obesity in China. Its determinants contribute to childhood obesity. Its adverse effect of obesity on children's health, and also policies and actions have been released and taken in China in recent years. This slide shows the systematic review analysis for global burden of this study, which published in Essence in 2014. From this slide, we can find that there is an increasing trend for the overweight and obesity, not only in developed country, but also in developing country, and also from other sources we can we all know that obesity are increasing not only among adults but also among children. In China, we have secured children nutrition and health surveillance system. From the information during the period of 1985 to 2014, we can find that the detection rate of overweight and obesity among school-aged children are increasing dramatically since 1980s. The increasing trend are keeping until now. In December 24th, 2020, the State Council Information Office, China, organized a press conference to release the report of the nutritional and health status of Chinese people. From this report, we can find that for adults, the overweight rate was 34.3%. For obesity, it was 16.4%. For children aged 6 to 17 years old, the overweight rate was 11.1%. The obesity was about 8%. For children under 6 years old, the overweight rate was 6.8%. For obesity, it was 3.6%. For the childhood obesity among Chinese people, Chinese children, it has its own characteristics. For example, among Chinese people, the overweight rate is higher than obesity rate. Obesity are higher among boys than among girls. Obesity are higher among children with a higher socioeconomic status than those with lower socioeconomic status. Obesity higher among urban children than their rural counterpart. However, in the past 10 years, rural childhood obesity rate has experienced a steeper increasing, which we should pay much attention on this change. We all know that obesity is a result of the interaction between obesity-related genes and the environmental factors. The environmental factors, including the dietary intake, physical activity, behavior, social economic status, and social culture factors. Obesity is the result of those factors interacted. We all understand that childhood obesity has adverse effect on children's health, including the adverse effect on their respiratory system, alimentary system, urinary system, locomotor system, nervous system, and also cardiovascular system. Therefore, we should pay much attention on childhood obesity in order to control and prevent those adverse effects. Childhood obesity also brings economic burdens. A publication in the United States indicated that obese children between 6 to 19 years old spent extra $320 US capita per year than their normal weight counterparts for the direct medical cost. Another review indicated that during 1998 to 2013, obese children spent $190,000 US more for their medical cost compared with their normal weight counterpart throughout their lifespan since 10 years old. In order to fighting with the rapid increase of childhood obesity, the international organization like WHO and also many countries have released the policy and take actions in order to fighting with the childhood obesity. For example, in 2014, WHO established a commission on ending childhood obesity, and in 2016, WHO released the report of the Commission on Ending Childhood Obesity. In this report, it proposed the evidence-based recommendation to eliminate childhood obesity. They have made six recommendations in this report. In recent 5 years, many countries, including the United States, Australia, Japan, and many European countries has developed and released the guideline for prevention and control of overweight and obesity in children. In May 11th, 2017, the report on childhood obesity in China have been released. In this report, we have made 5 recommendations, including obesity prevention and control, including all policies. We recommended that the control and prevention of childhood obesity should be led by the government. There is a need for the multi-sector cooperation and participation of the whole society. The third recommendation is the improvement of national childhood obesity surveillance system. The fourth is carrying out primary, secondary, and tertiary prevention of childhood obesity. The last one is the greater investment in in-depth and systematic research about childhood obesity. In the year of 2018, we, in collaboration with the UNICEF China office, we released a report on consumption of sugar-sweetened beverage of children in China in order to address the attention of the over consumption of sugar-sweetened beverage. There are also policies have been developed and released, and also some action have been taken in China in order to foster the healthy lifestyle and also to control and prevent of obesity. For example, in 2007, the Healthy Lifestyle Campaign for All was launched. On the same year, the guideline on the prevention and control of obesity and overweight among school-aged children in China was released. In 2014, the State Council released the outline of the Program for Food and Nutrition Development in China. In 2016, the State Council released the Blueprint of Health China 2030. In 2017, the State Council released the National Nutrition Plan for the year of 2017 to the year 2030. The good news is in 2020, the implementation plan for obesity prevention and control of children was released. And also this year, last month, the guideline for the prevention and control of obesity has printed out. I just share some more information about the two recently action. For the implementation plan for obesity prevention and control in children and adolescents, it released in October 23rd, 2020. It was issued by six governmental sectors, including National Health Commission, the Ministry of Education, State Administration for Market Regulation, the General Administration of Sport, Central Committee of the Communist Young League, and also All China Women's Federation. In this implementation plan, the prevention and control goals have been set up. For example, take the average annual increase in overweight and obesity rate from 2002 to 2017. The baseline from 2020 to 2030, the national goal was 70% decrease from the baseline. The goals also set up according to the difference in different regions. For example, the higher epidemic areas, the control goal was 80% decrease from the baseline. For the middle epidemic area, 70% decrease goal from baseline was set. For the lower epidemic areas, 60% decrease from the baseline. It also recommended some key tasks. For example, strengthening family responsibility and give full play to the role of parents and caregivers. Strengthen school responsibilities to maintain healthy weight. of children and adolescents, etc., etc. The guideline for the prevention and control of obesity in children was just released, print out last month. We spent 2 years to develop this guideline. We organized the experts from different areas from all over China. It covers 5 areas. The first one, the first part is the development of childhood obesity in China. We introduced the trend of childhood obesity among children in China. The second part is the screening and the evaluation of childhood obesity. The third part is the prevention of obesity in normal weight children. We have 3 sectors. One is the prevention of fetal and infants obesity. The second one is the dietary intake and the eating behavior. The third one is the physical activity and the lifestyle. The fourth part is the control and the treatment of children. The control and the treatment of obesity in children, including 4 sectors. One is the dietary adjustment. The second one, physical activity guidance. Third one is the behavior corrections. The last one is the drug and surgical treatment. We all know there's some progress in treating childhood obesity in recent years in using of drugs and surgeries. Therefore, we provided some information in this part, but it was not recommended very strongly. The last part is the supportive environment for the prevention and the control of childhood obesity, including we emphasize the responsibility of family, schools, and kindergartens, and also we also emphasize the importance of the community environment and the social advocate. This is the information I would like to share with you. Thank you for your attention. Thank you.
I'd like to thank Professor Dr. Ma Guansheng for this discussion on the control and prevention of childhood obesity. A lot of lessons to learn there from China. Our next conference speaker is Marjon Bakra from the Netherlands. She is the current managing director of the Dutch JOGG, for short, JOG organization, with a professional background spanning both the private and public sectors. She has spent her entire career on youth development, family, and social welfare. JOG promotes a healthy weight for young people, and she has proudly led this initiative since 2012. That's 9 years of active service in the interest of the young. Today, she speaks to us on the Dutch JOG approach, reshaping the environment of today's youth.
So thank you for the invitation to speak here today. Over the next 15 minutes, I hope to show you my dream and my goals, healthy youngsters with a healthy future. But first, let's start by asking you a question. On average, how many times a day do you make food choices, you think? Would it be 50 times or 100 times, or maybe 200? Just take a second to think about it. So every day, at least, we make 200 food choices, and all around us, we are constantly being enticed to eat too much, and often unhealthy food at that. In addition, we don't get enough exercise, not least due to our use of electronic devices like tablets or our smartphones, and our society expects us to be competitive and always available, and that makes us feel more stressed, and so we don't sleep as well. In short, today's society encourages us to adopt an unhealthy lifestyle. And it's very difficult for children, for youngsters, but also for their parents to make healthy choices in this environment. Certainly, if you also have social problems and are struggling, for instance, with debt, with poverty, or with relationship difficulties. According to the World Health Organization, obesity is one side of the double burden of malnutrition, and today more people are obese than underweight in every region except Sub-Saharan Africa and Asia. Once considered a problem only in high-income countries, the phenomenon of being overweight or obese now dramatically is on the rise in low and middle-income countries, and then particularly in urban settings. I would like to present to you a few facts. 38 million children under the age of 5 were overweight or obese in 2019, according to the World Health Organization. And in the Netherlands, 12.8% of children between the age of 4 to 20 were overweight or obese in 2018. And international studies estimate that the cost of childhood obesity over an entire lifetime amounts to 150 euros per child. But obesity is preventable. And I really believe that is what we should do. We should try and do everything about it to prevent it. Obesity and overweight are not specifically mentioned in the Sustainable Development Goals, but there are a number of goals which also demand action in these areas. For instance, the SDG number 3, ensure healthy lives and promote well-being for all at all ages. By 2030, they want to reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment and promote mental health and well-being. But also SDG number 2 says end hunger, achieve food security, and improve nutrition and promote sustainable agriculture. In the Netherlands, JOC is dedicated to enabling the younger generation to grow up in a healthy environment. JOC really wants to see that every child and adolescent in the Netherlands can grow up in a healthy environment where the focus is on a healthy lifestyle. I want to explain to you a little bit about what we do with JOC and a little bit about our local JOC approach. The local JOC approach is an integrated method in which the social and physical environment in which children and young people grow up is made more healthy across the board. And when you look at these environments, you see, I'm sorry, I just want to talk to you first about our target group, because our target group are children and youngsters between the age of 0 to 19. And we focus on the environments where these children spend most of their time. Of course, they spend most of their time at home with their parents, but also at school, in the neighborhoods, in the sports club, for instance, or where they spend their free time. And for the youngsters who are a little bit more older, where they work, and of course, where they spend their time on social media. And what we do with JOC, we support Dutch municipalities on the basis of 6 key conditions. This means that we help these municipalities to arrange local political government support. We help them to arrange public and private sector cooperation. We help them with working with the target group, with making the link between prevention and healthcare, with making what they do in their municipalities visible through communication, and we help them with monitoring and evaluate this approach. And on top of that, we take action through a local work net consisting of policymakers, professionals, and all the adults that surround the child. And this makes it easier in all these different environments to make sure that children drink water instead of sugary drinks, they eat healthy food, they will get enough exercise, and they will sleep better. And just to give you an example of what this means on a local level, at schools in Jog municipalities, children walk the daily mile. This means that every day, lessons are interrupted for 15 minutes to enable the children to run around or jog at their own pace with their classmates. And in school, they drink water instead of sugary drinks. And another example with our Team Fit program, we make sure that healthier food selections are offered, for instance, in sport canteens and other catering facilities. But of course, the child that is already overweight or obese is not forgotten. For these children, we provide appropriate care and support through the On the Road to a Healthier Weight program, in which we look more widely at the family, taking into account possible social problems as well as lifestyle. And we have some results at this moment in the Netherlands, of which I'm very proud. At this moment, in 32 municipalities, we see a reduction in children's BMI score. But also a PhD research done at the University of Groningen showed that Jog appeared to be successful in targeting areas where overweight was most prevalent. Areas with a lower socio-economical status that had implemented Jog for a longer period of time appeared to be successful in decreasing overweight prevalence. And in the neighborhoods where the Jog approach has been implemented for 4 years, the measured percentage of overweight children and adolescents was 9% lower than in other neighborhoods with this approach, as shown by a study done by the National Institute of Public Health and Environment. But it's not, it's not just the local network which is important. We also foster national and international cooperation. We currently work with 178 municipalities in the Netherlands, and this number is still growing. And in addition to that, we work together with 41 official partners and a great number of project partners. For us, it's really important to learn from other countries. So on an international level, we share knowledge, best practices with organizations all over the world. And we do this via the Youth Health Community Network, which we host. Public-private sector cooperation is really important for the Jog approach. So the commercial sector plays a really big part in our WorkNet. And our aim is to bring the relevant parties together in our WorkNet to have more impact on the Jog goals. And to give you a small example of what we do, for instance, with Aldi, which is a supermarket chain in the Netherlands, we have worked with Aldi for a number of years now, and they are genuinely motivated in their business to make children's surroundings more healthy. For example, since 2018, they no longer sell energy drinks to children under the age of 14. They've also entered into a partnership with Disney, and together they are using Disney characters to promote healthy products, as you can see on the slide right now. And they are working to create a healthy environment work floor for their younger employees. However, there is still a long way to go. In 2020, UNICEF report stated that almost 3/4 of all Dutch supermarket food products aimed at children are bad for them. This means they are unhealthy. UNICEF looked at over 2,000 products for children, including breakfast cereals, desserts, and drinks to see if they had a place in the government healthy eating recommendations. And most products turned out to have too many calories, contain too many salts, sugar, and saturated fats, or were too low in fiber. UNICEF also found that the supermarket showed no reticence when it comes to promoting unhealthy products for children, particularly through the use of popular cartoon characters. So coming to the end of this presentation, I would like to call on everyone here today to step up, to think about what action you can take in your organization or in your company to make the environment for our youngsters healthier. Please do your utmost to make it happen and ensure that this concept becomes part of your DNA of your business. And that is because it takes a village to raise a child. Thank you very much.
I'd like to thank Majan Bakra for that excellent delivery on reshaping the environment of today's youth. And as she spoke, I only thought, how lovely would it have been if I had only heard such truths when I was a youth. But who knows? I should be able to use that for the next generation. Thank you very much for your presentation. Our next speaker from Nigeria will be speaking to us on dietary practices and nutritional status of under 5 children in Nigeria. Dr. Olumuyiwa Adeyemi Owolabi is a doyen of community and public health nutrition at the Ahmadu Bello University, Zaria, Nigeria, with over 30 years of field experience in nutrition. He is a well-published academic and has contributed to policy on improved nutritional status of most vulnerable groups in Nigeria. A warm welcome to a man whose knowledge is sure to add to whatever we have known before today.
Thanks. My name is Olumuyiwa Adeyemi Owolabi from Nutrition Section of the Department of Biochemistry, Ahmadu Bello University. I'm happy to be here. The title of this presentation is Dietary Practice and Nutritional Status of Under 5 Children in Nigeria. Dietary Practice and Nutritional Status of Under 5 Children in Nigeria. The outline for the presentation will start with the country profile, then we'll look at the trend in infant and child mortality, dietary practices in terms of the infant and young child feeding practices, the exclusive breastfeeding, complementary feeding, and micronutrient supplementation. Then we'll look at prevalence of anemia in Nigerian children. Then that leads us to look at the nutritional status of under 5 children and be able to see the progress we are making towards targets. Then we'll look at the causes of malnutrition generally and be able to have a glimpse of the rays of hope and recommendations. We'll start with the Nigeria country profile. Nigeria is the most populous country in Africa with about 200 million people. Incidentally, also that gives us the 7th wonders of the world to be the 7th largest country in the world. And we have a thriving youthful population of about 60% youth with a mean age of about 18 years. The country is divided into 6 geopolitical regions of 36 states and having the Federal Capital Territory in the center of the country, also having 774 local government areas. We'd like to also say Nigeria is the baby capital of the world, giving birth to 7.6 million babies annually. And Nigerian also rank by the H system performance, the 187th of 191 countries. And also in terms of progress that have been made in the Sustainable Development Goal, Nigeria rank 145th out of 157 countries. Nigeria also have the largest economy in Africa with a GDP per capita of about $2,250. Unfortunately, about 70% of the population live below the poverty line. And because of malnutrition, the country loses a whooping $1.5 billion in GDP annually. So this is rough the gross profile of Nigerian nation. We look at the trends in infants and child mortality. While we know that malnutrition is one of the world's most serious but least addressed developmental challenge, the human and economic costs of malnutrition is very high. and it fall hardest on the poor, women, and children. Malnutrition alone is accounting for about 56% of this child death, and 83% of this death are directly related to mild to moderate malnutrition. Presently in Nigeria, by the current NDHS 2018 survey, neonatal mortality stood at 39, infant mortality 67, and under 5 mortality at 132 deaths per 1,000 live births. The implication of this is that 12.5% of all the children that are born dies before their 5th birthday, meaning 1 in every 8 child dies before their 50th birthday. In terms of trend, looking at the trend from 1990 to date, and the trends, instead of decreasing, increases even between 1990 and 2003. From 2003, there have been a decline. It's just that the decline is not as sharp as we would have loved it to be. The infant mortality from 2003 moved from 100 to 67 presently. The under 5 mortality moved from 201 in 2003 to the present 132. But neonatal mortality has not changed over this period. It has not changed over this period at all. So what are the dietary practices? The infant and young child feeding practices. Exclusive breastfeeding among children that are less than 6 months, which is the recommended feeding practice for children from birth to 6 months, is still about 29%. And this is an improvement from what we have in 2013, where the exclusive breastfeeding practices moved from 17 to the present 29%. Exclusive breastfeeding, in its own case, is relatively low, and this is because of the cultural practice. And the culprit here is the giving of plain water to infants, as well as introductions of complementary food quite highly. From the pie chart here, the exclusive breastfeeding practice is 29%, but you see that another 39% are doing breastfeeding with addition of plain water, and another 22% is having breastfeeding with highly complementary food. So the most easiest point is to get those who are adding water as a convert. If you had those who are having water as a convert, if you can get majority of them to stop bringing water, just in a year we can move from the paltry 30% to over 60%, because it's 39% that are adding water to the breastfeeding practice. And this has its own much consequences. On complementary feeding practice, appropriate complementary feeding should include variety of food to ensure nutrient adequacies for the young growing children. After 6 months, breast milk alone will not be able to supply the energy and nutrients that the child will need to grow. So we need to add appropriate complementary feeding. And the appropriate complementary feeding here, it's noticeably only gruel that is made from cereal, and they are not, they don't have enough variety to ensure nutrient adequacy. The minimum dietary diversity stood at 23%, and the minimum meal frequency is 42%. Now, having the minimum acceptable diet, which is the IOSCF indicator number 7, stood at a paltry 11%. So just 1 out of 10 children in Nigeria between the age of 6 and 23 months had minimum acceptable diets. And if you look at this trend over the year, you see that the trend in 2008, 35%, and it moved to 11% from 35 in 2013, and still remain 11% at 2018. Even the 35% that we have in 2008 might be due to the change in international definitions. As 2008, we are still looking at in 2008, we are still looking at having 4 food out of 7. And presently, we are looking at having 5 food group out of 5. This is the IYCF indicator of minimum acceptable diets as of NDHS 2018. We have distribution of children by the type of food they consume. And this is, it gives us a picture of the food that we give our children. You see, food that are made from cereal constitute close to 80%, 78.3%. And we will see that food that comes from other milk is very low, about 12%. And this other milk will even still include some other milks from even up to soybean milk, cow milk directly, raw, unpasteurized. They are all part of this. Look at the consumption of meat, fish, and poultry, 27%. And most of these foods, egg is just about 12%. These are the foods that we use as a complementary food in Nigeria as of NDHS 2018 data. Prevalence of anemia in children, 7 out of 10 children in Nigeria are anemic. It's only that the forms of anemia differ from mild anemia to moderate anemia and severe anemia. 3% have severe anemia. And the prevalence of anemia is highest among children 6 to 23, specifically children between 12 and 17 have the peak of prevalence. 81% of them are actually anemic at that level. Children in rural areas are more anemic than those in the urban, and the prevalence of anemia show regional disparity to the level as shown in the picture in the graph of showing the country profile. Highest in the northwest and northeast, lowest in the southwest. The nutritional status of Nigerian children under 5, and we also want to look at the progress that have been made towards targets in terms of stunting, wasting, and underweight. An estimated 2.5 million children suffer from severe acute malnutrition, and this is the greatest contributor to the child mortality. And Nigeria now has program to address this severe acute malnutrition in the form of community management of acute malnutrition. We even have an integrated management approach presently. But those who survive this severe acute malnutrition will still have suffered severe consequences like lower intelligence quotient, stunted growth, impaired physical and cognitive ability, and eventually their performance in school and productivity in later years will be affected. So 2.5 million children affected by severe acute malnutrition. The other forms of malnutrition are also very high. Stunting, children that are short for their age. Nigeria is the second in the whole world with the number of children that are stunted presently, 37%. Wasted children that are thin for their height, are 7%, and children that are underweight, thin for their age, are 22%. We would like to point out that the 7% that we are seeing is as a result of this community management of severe acute malnutrition. And 2% of our children are also overweight. We are gradually moving towards the double burden of malnutrition. Like I said earlier, Nigeria has the second largest number of stunted and wasted children in the world. Now, the trend in stunting, underweight, and wasting We're not making much progress. The stunting in 2008 was 41, and by 2003, 37, and we still remain 37 in 2018. In 5 years, we have made little or no progress. Underweight moved from 29 to 22, but we are able to move wasting because of some of those programs from 18 in 2013 to 7 in 2018. And there's a wide variation by zone in the prevalence of stunting, showing that the highest is in the northwestern Nigeria, which is at 57%, and the lowest is in the southeastern Nigeria at 18%. This nutrition data at a glance, looking comparatively from 2008 to 2018 in the level of stunting that we have discussed, underweight and wasting. Also in anemia, also still high at 7 out of 10 children. The prevalence of exclusive breastfeeding at 29, we have discussed this, and the minimum acceptable diet at 11, and the coverage of iron from pregnant women is still at 31%. Pregnant women coverage is coming because it's eventually having effect on the level of anemia in infants that are born. And coverage of vitamin A supplementation in children still stood at 45% at 2018. Now, these have mentioned those issues. Now, looking at the progress that have been made to the global nutrition targets, this is from the Global Nutrition Report 2020. You see that we have made no progress regarding anemia or even its worsening. Low birth weight, we don't even have data to be able to talk about it. Exclusive breastfeeding, we have made some progress moving from 17 to 29. On five stunting, we have made no progress. Stunting still at 37% and having the second highest number of stunted children in the world. Under 5 wasting, we have made some progress, reducing to bare 7% that we can still put further. Under 5 overweight, we are on course because we are presently reduced it to 2%. What are the basic causes of malnutrition? The conceptual framework for the causes of malnutrition have been developed from the ICN, International Conference on Nutrition, since 1990, and it still stood. And we have the basic cause, the underlying cause, and the immediate causes. And the systemic level of challenge is reflected in the structural and the political process of the country. Evidently, we have poorly developed health system with no adequate and functional surveillance system. And this is the basic issues that affect issues regarding nutrition and health. Climate change is also another thing that worsens nutrition and health problem in Nigeria. If no action is taken, immediate action are taken regarding climate change issue, it will affect food security issues, and eventually it will be a move from an underlying cause to a basic cause seriously for us. Then they intensify existing challenge of communication disease and food securities. These are the issues that are basic causes. The underlying causes are what we found at the community level: failure to obtain proper nutrition due to food insecurity, inequitable distribution of wealth, poor housing, and major issues. Poor feeding practices that we have seen, which in most cases from ignorance about the benefit of adequate breastfeeding and complementary feeding practice, are the major cause of the malnutrition. Poor and inadequate healthcare system is another cause of malnutrition. We have low maternal nutritional status, and it will eventually lead to low birth weights, and this will lead to intergenerational cycle of malnutrition among the populace. The immediate cause of malnutrition is actually inadequate intake, or where there is adequate intake, there is poor absorption that comes from disease and infections. These are the immediate causes. And when the health system is weak and there's a lot of disease-causing agents and infections, then you expect the link between malnutrition and infection to drag towards malnutrition and eventually death. So diet-related non-communicable diseases are also on the rise due to globalization, urbanization, lifestyle transitions, social cultural factor, poor maternal and fetal infant nutrition. These are the immediate causes that we have seen in malnutrition. In all this, we can still see a ray of hope because the policy environment is changing for the better. Nigeria now have a brand new nutrition, national food and nutrition policy, and we now also have the National Strategic Plan of Action for Nutrition that is currently being implemented. And the goals of these documents and these policies environment is to improve the nutritional status of Nigeria, especially the vulnerable group, the children under 5 and the women of reproductive age. There is visible political will from the political actors in Nigeria to change the narratives regarding malnutrition in Nigeria. Presently, Nigeria have established Nutrition Council at the presidency, and the chair of the Nutrition Council is the vice president of Nigeria. Nigeria begin to see for the first time budget line for nutrition, both at the federal and the state government level. So improvement and sustenance of this will begin to bring a positive change. Another ray of hope is that we have willing friends and partners that are ready to partner with Nigeria to make sure that the issue of malnutrition becomes things of the past. There is also availability of trained manpower at the highest level, at the medium level, at the lower level to execute proven nutrition-specific and nutrition-sensitive programs in Nigeria. This manpower is there for nutrition. Then we begin to see improved care-seeking behavior from our caregiver. The care-seeking behavior is beginning to improve. They can demand for this nutrition activity. And this is a ray of hope for us as a nation. The recommendations that we put forward to let us translate the ray of hope into actions is one, improving basic education attainment among girl child, especially the adolescent girls. This will go a long way to improve the indices of nutrition, because even the NDHS disaggregated data shows that caregivers that are educated, the indices of malnutrition in their children are better off. Secondly, we need to institutionalize nutrition counseling and nutrition education at community level. In this case, we need to target the whole community, not only the caregiver. We ran into this when we are doing exclusive breastfeeding. We are targeting the caregiver. So, and there are some other people within the community that are role model. If they don't, the gatekeepers. So we need to carry the whole community together so that there will also be a compelling issue and encouragement on the caregiver to practice improving nutritional issues. Third one is improving behavioral change communication strategy, so that after counseling and nutrition education, we will not be stopping at the issue of knowledge. The knowledge will be translated into practice. Then incorporating nutrition concern to improve healthcare packages, improving our weak healthcare system. Then we have to leverage on improved agricultural practice worldwide to promote nutrition-sensitive agriculture. Next, we have to link agriculture, nutrition, and gender so that we can empower women positively to be able to also cater better for their children. We have to shift focus on adolescent nutrition as the second window of opportunity to break intergenerational cycle of malnutrition. Our interest in nutritional concern has been focused on just under 5 children or probably women of reproductive age. We need to look at adolescents so that we can break the intergenerational cycle of malnutrition through them. Then lastly, we need to improve access to nutrition intervention among the hard to reach under 5 children, women of reproductive age, and adolescent girls. this recommendation will be a far-reaching effect. I want to thank you for listening. Thank you very much.
A very warm thanks to Dr. Adeyemi Owolabi for his brilliant presentation. Our last speaker in this segment is Professor Dr. Damayanti Rusli Jarif. She is currently professor in the Faculty of Medicine, University of Indonesia, and consultant pediatrician for nutrition and metabolic disease in Dr. Sipto Magunkusumo National Central General Hospital. Currently the head of the working unit of food for special uses in the Indonesian Ministry of Health. She is a board member of Asia Pacific Society of Gastrohepatonutrition. She will be speaking to us today on the importance of prevention of malnutrition, an Indonesian example.
Good afternoon, ladies and gentlemen. Firstly, allow me to thank the organizer for inviting me to share my presentation about strategy to prevent stunting, the most prevalent form of childhood malnutrition worldwide. I will divide my presentation into 3 subtopics as mentioned in the outline. According to report of Joint Committee for Childhood Malnutrition, stunting is the most prevalent childhood malnutrition, exceeding wasting and overweight, with 144 million children had stunting and 56% of them live in Asia. WHO definition stated that stunting is short stature or stunted due to chronic or recurrent undernutrition. I try to interpret the definition into simple classification that chronic malnutrition could cause by inadequate nutrition intake due to poverty, neglected and ignorancy, and increased requirement due to the frequent illness. I will proceed with the pathogenesis and impact of stunting. Stunting always beginning with weight faltering and followed by length deceleration. Hope study showed that 7 days of 50% caloric restriction and 33% protein restriction will result in an IGF reduction. Without adequate intervention, linear growth faltering will end up as stunting with short and long-term impact on quality human resources. Stunting is a marker of multiple pathological disorder associated with developmental delay, depressed immune function, defect of cognitive function, impaired fat oxidation, and will elevated risk of chronic disease in adulthood. I tried to summarize the effect of undernutrition on cognitive, from weight faltering through wasting and stunting pathway, or length deceleration and stunting pathway. Without adequate intervention, both pathway will reduce IQ up to 20 points. Is the impact of stunting reversible? The study of Granta McGregor showed that nutritional supplementation with or without psychosocial stimulation improved significantly in the Q more than control group. The supplemental plus stimulated group improved significantly more than the stimulated or supplemented only. The Cebu Longitudinal Health and Nutrition Study assessed the relationship between stunting in the first 2 years of life and later cognitive development. In this cohort, children still stunted at age 2 had a marked delay in initial school enrollment. This figure indicating that stunted and non-stunted children benefited similarly from additional schooling, but after multivariate adjustment, severe stunting at age 2 years remained significantly associated with later deficit in cognitive ability. All previous results emphasize the need to prevent early stunting and to provide adequate schooling to disadvantaged children. Since stunting is due to chronic malnutrition, is there any specific type of nutrient associated with stunting? According to Golden classification, growth failure is the clinical characteristic of type 2 nutrient deficiency of protein, energy, zinc, magnesium, phosphorus, and potassium. A meta-analysis showed that protein is the most important factor associated with increased linear growth. However, affect multiple micronutrients to linear growth only led to an increase of 0.09 centimeter per year. It is far from expected. It's supposed to be 25 centimeter increase in the first year of life and 10 centimeter per year until the child reaches 5 years old. So we find, although statistically significant, but clinically non-significant. The SEMBA study showed that stunted children have lower serum concentration of all 9 essential amino acids compared with non-stunted children. Essential amino acids are considered essential because they cannot be synthesized endogenously and must be obtained from diet. The best source of essential amino acids are animal protein, like milk, meat, fish, egg, and poultry. Consuming more than one type of animal source food is associated with significantly lower risk of stunting in the 18 to 23 months of age group. Based on previous evidence, we suggested strategy to prevent stunting before age 2 years, first by application of infant and young child practice that explicitly promoted affordable animal source food as a part of guideline for infant and young child feeding. Secondly, regular growth monitoring to detect early and treat promptly with faltering and growth deceleration. The Infant and Young Child Feeding Guideline by WHO 2003 showed that the importance of breastfeeding and complementary food in that period. Human milk contains essential amino acids similar to other animal source protein. Breast milk provides a significant daily protein requirement of infant and young children, but the quantity should be carefully monitored. Our study of 100 mother-baby pair for promoting 6-month exclusive breastfeeding succeed in 84% diet, but weight faltering found in 30% of patients in 3 months, which increasing to 16% at 6 months. Without immediate intervention, weight faltering will proceed to stunting. Based on this the complementary food, according to WHO feeding guideline, complementary food should be introduced timely when the need of energy and nutrient exceed what can be provided through exclusive and frequent breastfeeding. Based on that finding, Indonesia Pediatric Society recommended Ministry of Health in 2015 the application of algorithm if infant experience weight faltering during period exclusive breastfeed, evaluation red flags, correcting management lactation, and weight gain monitoring after 1 to 4 weeks. If weight gain sufficient, proceed with exclusive breastfeed, but if insufficient, add complementary food, liquid or solid depend on age and oromotor skill readiness. Complementary food should provide sufficient energy, protein, and micronutrient to meet the growing child nutritional needs, which is already insufficient beyond 6-month breast milk. The report from 48 countries showed that prevalent stunting associated with consumption animal source food. This evidence showed that to reduce stunting, consumption more than one animal source food is recommended. The second strategy is regular growth monitoring. Onyango study showed that prevention of weight faltering would prevent stunting, estimated up to 34% at 12 months and 24% at 24 months. Weight increment less than percentile 15 classified as weight faltering according to Onyango study, and growth deceleration classified if length increment less than percentile 5. Both strategy was implemented in the pilot project of stunting prevention action in Pandeglang, Indonesia, in the Integrated Healthcare Center Bayumundo Village, Pandeglang, in 2018 to 2019. Nutrition counseling to consume local animal source protein every day since 6 months old, forbid sweet condensed milk, reduced stunting 8.4% in 6 months. The strategy looked promising. Finally, the take-home message: in the setting where childhood undernutrition is highly prevalent, affordable local animal source food should be explicitly promoted as a part of guideline on infant and young child feeding. Regular growth monitoring with intention to detect early and prompt treatment of weight faltering is proven to reduce the prevalence of stunting significantly. Thank you for your kind attention.
I'd like to thank Professor Rusli Jarif for her brilliant and insightful presentation. I will now ask participants to please stay tuned for the panel discussion, which will focus on healthy diets for health improvement in children. And some of our esteemed speakers will be taking part in the panel discussion. Further instructions will be given by the FrieslandCampina Institute team. Thank you very much.